Okay, so always feel the pressure a little bit more right before the reception here, but we'll try and stay on time. So my name is Rocco. I'm one of the infectious disease fellows at NIAID, working in the laboratory of immunoregulation. And I'll be talking a little bit about some data we put together on a cohort that was actually collected very early in the pandemic, and we'll highlight some of the unique findings and some of their implications. Fortunately, I don't have to go through background on the COVID-19, as we're all very familiar. And we've been talking about the pathogenesis all day today and really emphasizing the importance of this innate immune hyperactivation, the myeloid activation contributing to the hyperinflammatory response, as well as sort of coagulopathy, vascular endothelial damage, complement activation. And in this cohort, which I'll mention, we really checked this really broad biomarker panel, evaluating sort of each of these different pathways to try and gauge their importance during earlier presentations of the disease before they progressed. And one of the earliest clinical findings was, of course, metabolism. So we included some metabolic markers as well. So this was a very unique cohort. It actually no longer exists in the world because it was collected at the very first wave of the pandemic in Italy, in two southern Italian hospitals. One was more rural, the other one more urban. And fortunately, these samples were actually prospectively and consecutively collected within 1 to 3 days of hospital admission. And at that point in time, every patient that tested positive for COVID-19 in Italy was admitted to the hospital. So we had a very broad range of mild to moderate to even severe critical disease. And overall, this was a retrospective cohort, so we had the disease outcomes. So we graded the patients into groups based on what their worst disease was that they developed during the hospitalization. And the severe critical group was really defined as anyone that required supplemental oxygen at any point in time or worse than that. And this cohort was put together. The data we collected was from discarded plasma and serum samples, which, as I mentioned, were collected within the first few days of presentation to the hospital. So the age, which we'll talk about, was different, as would be expected, between the severe critical and the mild moderate group. It was fairly balanced by sex. The one thing I did want to highlight is the BMI. It was actually, the median was 24, 25 between the two groups, and it was a very fit group of patients, which is probably different than we may see in the United States. And of course, a very important variable of the time of symptom onset to lab collection to try and really gauge at what stage of the disease they're in. And in all of the logistic regression analysis that we performed, we controlled for this, and we actually did a number of sensitivity analyses to limit the effect of this confounder on the study. So our analysis was simple. We ran logistic regression for those with severe critical disease compared to those with mild moderate. We did the same for in-hospital mortality. Any patient that we only had 10 deaths in the entire cohort, and every other patient survived to discharge, so this was in-hospital mortality. And we also performed a multivariable regression for only the severe critical disease because we had greater power there, and ran some correlation network analyses and decision tree analyses. Just summarizing kind of the categorical variables, which are primarily the clinical characteristics. You know, it's not super surprising. COPD was strongly associated with severe disease, as was hypertension. Interesting things that have been described in other populations: obesity, coronary artery disease, diabetes, not significant in our population, but as I mentioned before, again, this was a population with a median BMI of just 24, 25. So it was not really a high-risk population for those diseases. And looking at the immune biomarkers, and we find interesting to, and complementary to many of the studies that have already been presented today, but actually some of the strongest markers, even earlier in the disease course for severe disease, were these endothelial activation markers. Now, there was pretty large heterogeneity across even the severe disease patients, so we get large confidence intervals, but really strong odds ratios for the endothelial activation markers, things like soluble CD14, complement 1Q, et cetera. Now, one of the really interesting findings was, I mentioned the metabolic markers before, is there's actually a strong association with protection from severe COVID-19 with irisin. I'm not sure how many people are familiar with that, but irisin is a really interesting immunometabolic marker which has a lot of immunoregulatory properties, most of which, I guess to give some background, it's produced by skeletal muscle. It's involved in converting sort of white adipose tissue to brown adipose tissue. It's been studied extensively in mice, and it has this downregulation effect on pro-inflammatory macrophages and leads to a shift of sort of M1 to M2 and can downregulate a number of innate signaling pathways related to TLRs and mTOR, et cetera, which makes it a very intriguing marker and protection potentially from severe COVID-19, which we know impacts many of those pathways. And as part of the multivariate regression, feeding all of the sort of positive variables into regression analyses, the ones that popped up positive are, again, things that we are very familiar with. Age, of course, D-dimer reflecting the coagulopathy, and IL-6, which we know, of course, is strongly associated with severe disease. Interestingly, when we fed sort of these biomarkers into a decision tree analysis, which selects sort of the most differentiating biomarker of the group that associates with severe disease, pentraxin 3, which has been reported in 2 or 3 other studies as well, was the best differentiating biomarker, again, reflecting this sort of innate immune importance and maybe predicting patients that are going to progress to more severe disease. And of course, as we know, age as well turned out to be positive. I'll go through the mortality data a little bit more quickly because, of course, we were limited in power because there's only 10 deaths in the entire cohort, but it really mirrors the severe critical disease as well, with a lot of the endothelial activation markers being associated with death, albeit with large confidence intervals, as well as a number of the innate immune signaling molecules. And irisin, although it sort of trended towards a protective effect as well, it had a very large confidence interval that was not statistically significant. Interestingly, leptin, another one of the metabolic markers that we checked, it did associate with protection from mortality, maybe further reinforcing there may be more to this metabolic story than we are aware. And then finally, just to end, I'll talk about the correlation network analyses, because I think there's another very interesting pattern that we found. You know, in those with mild, moderate disease, and the lines here represent positive associations of greater than 0.3 or higher that were statistically significant when controlling for multiple comparisons. The thicker the bar, the stronger the association. And in a mild, moderate cohort, there was a lot of associations between these complement markers, C3a, C5a, C1q, with endothelial activation markers, which makes sense, ICAM, VCAM. But when we looked at the correlation analyses in the severe critical patients, those associations disappeared, and there was a strong upregulation actually in correlations between a lot of the innate immune activating markers, pentraxin, IL-6, and markers like CD14, IL-27, as well as some of the endothelial markers. So to wrap up, reinforcing, as we all know now, the really strong innate immune activation, myeloid activation is associated with severe COVID-19. The endothelial system's clearly involved and interesting, can have even early in disease. Again, a lot of these patients, although they presented to the hospital earlier, we don't know exactly in the disease course where they were, may have already been showing signs of this pathologic endothelial activation, potentially indicating that may be a prognostic factor. And then there's probably more to learn in the metabolic side of things, markers that are associated with health and more immunomodulatory, and these should be looked at further going forward. I think one of the interesting things is really, as I mentioned, this is a cohort that doesn't exist anymore, and this is a study that was done in a completely immunologically naive population. And the question is now, really, how do these impact the patients that we see nowadays? Do we see a similar biomarker pattern, or is it completely different pathophysiology? It's really hard now, or at least we have struggled with it at the NIH, putting together a cohort where you could get the patients presenting early in disease and then seeing them if they progress to severe disease, because of course we have so many treatments now and other things that can impact this. So longitudinal markers and following those patients that will eventually progress is hard to do but would probably teach us a lot about how this immune response can really impact the pathophysiology of the virus. And many thanks to all of Severity lab, many of which are here, including Irini and Andrea Lisco in the lab, who was instrumental in helping collect this cohort. And then really the biggest thanks goes to the people in Foggia and Bari who helped collect these samples, collect this data, and we were able to work closely with them to put this study together. And I will close there and take any questions whenever there's time.